I'd like to welcome you to this edition of the PRS Journal Club podcast with your hosts, Dr. Sammy, Sinno, Amanda Silva, and Raj Sawh-Martinez. Enjoy.
Hello, everyone, and welcome to the July 2016 edition of the PRS Journal Club. My name is Raj Sawh-Martinez, and I'm joined by my fellow resident ambassadors, Amanda Silva and Sammy, Sinno. This month, we're privileged to be joined by Dr. Babak Mehrara. Dr. Mehrara, thank you so much for taking time out of your busy schedule. I know it's been a very hectic year for you, and so we're glad you can join us for this edition of the PRS Journal Club.
Sure, my pleasure.
So in this section, we'll be discussing a study by Dr. Rohrich and Riesemann, sorry if I'm mispronouncing that, on their long-term results in facelifting, observational results, and evolution of their technique. This is a very unique paper. It represents one of, if not the longest series of facelifts reported. And the authors discuss their experience that spans over 25 years and almost 1,100 facial surgery patients. The main goal of these authors was to review which specific factors they believed have been keys to achieving durable and consistent long-term results in facial rejuvenation, and they discuss their evolution of their practice. There are many great pros in this paper, but their main modifications of their technique have included, number one, less extensive facial skin undermining, 2, SMAS plication or SMASectomy, instead of an extended SMAS dissection. And 3, their main point is an open treatment of the neck. The authors also discuss the increased role of fat augmentation, the use of lasers and peels to resurface the skin, and the importance of patient selection. Briefly, less skin undermining was used to reduce the swelling and potential vascular compromises of these skin flaps. They recommended avoiding dissection of the nasolabial groove to avoid effacing that groove and distorting the oral commissure. They discussed sort of limited undermining in patients with minimal skin laxity and wide malar width, and patients that have narrow faces with deflated midface. There you may do some increased undermining of the skin and recruitment of that towards the zygomatic arch. In their SMAS work, they talk about the fact that they use deep plane SMAS dissections early on, but this has evolved into SMAS plication or SMASectomy with similar results without extensive dissection of the SMAS. Here, the authors note that patients with narrow faces who need more volume, they recommend SMAS plication, while patients with wider or fuller faces recommend SMASectomies. The SMASectomies, they say, are carried out in a perpendicular vector to the SMAS advancement and often in an oblique fashion at the junction of the static and mobile SMAS. Treatment of the neck is a hot topic. It's been widely discussed, multiple papers, and it's actually come up several times in our live Twitter journal clubs. Here, the authors recommend concomitant treatment of the neck via an open approach with neck skin undermining, fat excision via submental and lateral platysmoplasty, and they recommend doing this as a primary step during the facelift procedure. They say that this will reduce the recurrence of platysmal bands from more conservative approaches. Lastly, I'll just briefly mention that the authors really highlight the importance of patient selection contributing to long-term results. They sort of say that there's equal part to the technical abilities of the surgeon. And they say that, the best patients who have the more lasting long-term results are those who are younger, in their 40s, who have prominent cheekbones, strong jawlines, and who maintain their soft tissue result over long term by using some of the adjuncts, including excellent skin care. One of the downsides of this study that the authors do note is that their follow-up was very difficult to attain beyond 3-year time point. They know that only about 10% of the patients had consistent follow-up to that point, and that they did present for many other procedures. This is an observational study. This is an author's description of their extensive experience, but there is no sort of quote-unquote hard data, and they note that it's very difficult to achieve that and to describe that, given that this is an evolution of a technique. But I think that this is a really valuable thing for the entire field of plastic surgery to have two expert surgeons discussing their evolution, their thought process, and their current recommendations. I'd be really interested to see what you guys think, and Dr. Mehrara, what your experience has been maybe in training with facelifts, or if you've done them, does this sound true to you? Is this what you were taught or what you do?
Sure. I actually do facelifts in my practice as well. You'd be surprised how many breast cancer survivors come back and want their faces done, once everything is done. So, and I follow a lot of these basic rules. I think the level of detail that these authors present is really great. The insights that they have about augmenting volume is a really nice touch about how to deal with a narrow face or a face that is volumetrically deficient. Interesting. They didn't really talk about fat grafting much, which I was a little bit surprised about, because I would be interested to see if they incorporate that into their practice. But a lot of the same techniques that they do, I think a lot of us use in our practice. I think the really mastery and the really key point of this is how they can individualize their approach for each patient depending on their facial shape and structures. So I think that's a really nice takeaway message from this.
I agree with that, Dr. Mehrara, that last point. I think we were fortunate to have Dr. Rohrich come last month and do some cadaver dissections, and he in fact does fat graft before he actually performs the surgical portions of the facelift. I think these articles that he writes are so great, and while they are necessarily extremely scientific, I think these are very key articles for surgeons to be able to have and pull and really understand how to do a safe, reproducible, and reliable facelift. And I think the last point you made about individualizing everyone's anatomy, I think in the age of minimally invasive procedures where there's a lot of poor specialists and non-plastic surgeons offering different modalities of facial rejuvenation, Botox fillers, lasers, ultrasound tightening, what have you, I think it's going to be really important for plastic surgeons to be able to do the two things that really distinguish plastic surgeons from any other specialists, and that's fat grafting and surgery. I always think about the reconstructive ladder, or as Amanda knows, Dr. Gottlieb talks about the reconstructive elevator. I think it's analogous to aesthetic rejuvenation of the face, in that if you can understand the aesthetic deformity, and if you're a real plastic surgeon that can understand how to manage these problems, you can offer patients anything from the low step of the elevator to the highest floor. And if you're able to do these procedures, you have the greatest degree of aesthetic control and really offer them optimal rejuvenation of the face and the neck by doing these graded approaches to the problem. So that's why I personally get a lot out of these type of articles.
Mm-hmm.
Right.
That's a great point. And the one thing that's interesting with the patient selection component, at least for me, they talk about sort of younger patients having stronger viscoelastic properties, and that's the way they think sort of they may maintain the results longer. But it's sort of a catch-22, don't you guys think? I mean, how many 40-year-old patients are really, often coming in needing or requiring facelifts, where I think people offer them more often, adjuncts, right? Fillers or peels, et cetera.
Well, yeah, I mean, I think you can make that argument about a few of these patients that are shown in the figures. I mean, these are great results, but like, for example, figure 4, she's got a very sort of subtle change, but I'm sure there'd be people who would offer her fillers and other approaches rather than doing a facelift. Although, but if you look at her carefully at her jowls, they definitely look better, and she has a long-lasting result. So,
and there's no doubt that bony support that's excellent will hold the facelift results more optimally. And
her results show, her results, stayed very good 9 years post-op. So that's great.
Right.
Yeah, it's very impressive.
There was a paper about the staged facelift, Raj, by Dr. Musto, in case anybody listening wants to read more about the viscoelastic properties of the SMAS, but that's a good point. What were you going to say, Amanda?
He injects that before he does the lift, so he does the augmentation and then he does the facelift after?
Yeah, so you broke up for a little bit there for a second, but I think you were asking when he does the fat grafting. He actually does the fat. He does the fat grafting before he performs any of the surgical maneuvers, and the reason he does that is, number one, he said firstly that he likes to be able to analyze the face before he's dissected the planes, before there's a lot of edema, so that he can precisely put the fat into the specified compartments. And number two, he says that, for him, fat grafting is an artistic endeavor that he likes to have his full energy for. So he likes to do that at the beginning of the case. Obviously, Dr. Rohrich doesn't have any energy problems from the 2 a.m. emails, but nevertheless, I kind of understand that he really likes to take his time and really artistically analyze the fat compartments and then place the fat where he thinks he needs to, and then perform the surgical facelift after that. Now, there are some people like Dr. Stuzen who does the opposite, for him, and he'll say, well, I want to see where I've repositioned surgically the tissues, and then I want to be able to actually supplement that. And, for him, he says, well, fat grafting to me is enjoyable, and I am done with the facelift. I can relax and harvest the fat and inject it. So I think ultimately it's a matter of preference, but most surgeons tend to fat graft just prior to actually performing the surgical facelift.
Dr. Mehrara, what do you do when you tend to do facelifts with fat grafting? Do you have a preference, or?
I prefer to do it after. Yeah, if I need it, I prefer to do it after, because I guess it's harder for me to judge where everything's going to end up after.
Right. Yeah. I would think. Yeah.
Right. And do you peel? Do you do chemical peels as well at the same time, or laser resurfacing?
I typically don't. No, I usually I have a dermatology colleague who I send that to.
Got it. All right. Well, great. We would definitely recommend everyone reading this paper in detail. Lots of other great pearls in there. Dr. Mehrara, thank you so much for your time and spending your evening here with us and discussing all these papers. Thank you guys very much. We'll catch you guys next month.
Thank you, Raj.
Thank you.
Thanks, guys.